Great to see you. Thank you so much for your time this afternoon. Professor Tan, let's begin with you. And what's interesting is we'd like you to start by painting a bit of a broad brush picture in terms of cardiovascular disease. We do hear about the common impact of common chronic CVDs relating like coronary artery disease and peripheral artery disease. That's CAD, PAD. Tell us a bit more about that.
So cardiovascular disease actually encompasses a number of conditions: coronary artery disease, cerebral vascular disease, peripheral artery disease, and even atrial fibrillations. So if you can appreciate, actually all these conditions in some way share the same pathophysiology, which is that of an atherosclerotic process. So this is a process that involves hardening of the artery and then causing cholesterol and fat to be deposited within the arteries, forming what we call plaques, atherosclerotic plaques. Now, when this atherosclerotic plaque starts to build within the coronary artery, sometimes the surface of which can be broken and then trigger off a clot formation, and that choke off the artery supply and causing heart attack and stroke. So cardiovascular disease, as we all know, is actually the number one killer on this planet Earth. And so the disease burden is tremendous. The impact of the disease is not just on the patient. It is on the caregiver, it's on the family, it's on the society, and even the nation as well. And so, but the good news is that although this is a very common condition, we know that it is a lifestyle disease. It is a preventable disease. In fact, 90% of people with coronary artery disease or peripheral vascular disease will have at least one risk factor. And so because of that, it is a preventable condition, and this is something that we can all do to help to lessen the cardiovascular burden.
Professor, as someone who has so much experience, deep knowledge, vast knowledge over many decades in this area, that must worry you that you keep seeing this rise and rise of cardiovascular disease in this region. Is that a personal concern and a worry to you, somebody who's tracked this and seen this journey over many decades?
To a certain extent, I think cardiologists here are overworked in the public sector. So the volume of a heart attack is rising, no question about it. In fact, if you just look at the trend over the last 10 years in Singapore, the incidence of heart attack has gone up by about 60%. The stroke has gone up by about 40%. And so we are looking at about 10,000 over cases of heart attack a year and about 7,000 over cases of stroke a year. So every day, I always tell people that heart attack is a daily affair for us. So it's something that we do as part of our job and living. But the good news again is that the incidence increase is actually not due to actual more number of patients having heart attack, but because of the aging population. By sheer aging alone, it is already a risk factor. So the fact that we are getting more aged people in the country, and that naturally will translate into a higher incidence of heart attack and stroke. But the actual age standardized heart attack is actually pretty much the same, constant throughout the last 10 decade or so.
Interesting. Professor Chan, if you could give us a bit of a picture too, in terms of firsthand, you see the burden of cardiovascular disease on seniors, on caregivers. Help us paint that picture for us. And why do you believe that the release of these recommendations today is such a compelling narrative, and why we should be acting right now?
Well, I don't know if this is on. Is it?
No, it's not on. Thank you.
Well, I think one of the reasons that we should be acting right now is because when we talk about population aging, by 2030, 60% of the aged population will reside in Asia. And what a lot of people don't realize is that the fastest growing proportion are the 80 and over. And this is for every country. That means that the longer life expectancy will bring longer years with disability, as Minister Kaur mentioned. Now, families often struggle with the level of care and support required for their elderly family members after a heart attack, and this includes issues around transportation, rehabilitation, a general lack of knowledge of post-stroke care, and an increasingly small pool of caregivers. In one study that we did, only 20% of stroke patients appeared for rehabilitation services, and the main reason was due to lack of transportation. But when a stroke occurs or a heart attack, possibly a second family member will have to give up work or shorten their working hours to be a caregiver. So the impact, as Prof. Cheam was saying, goes far beyond the individual and can affect family dynamics, financial situations, and employment. So the report really highlights the importance for health systems to shift to more focus on preventive and primary care. For patients who are recovering from these events, we can support them and their families by bringing care to their homes and their communities to be able to alleviate some of these care issues. There's some pilots currently undergoing in Singapore, and I know Minister Kaur is intimately linked to one of them. It's called Care Close to Home. It's one nurse provider and 5 nursing assistants. Right now, this nurse is looking after 550 patients with disability, and they need all kinds of ADL support. We have to find a way through innovation to be able to provide more support, given that we have fewer and fewer personnel available.
Okay, very interesting. We'll talk a little bit about that shortly. If I could turn our attention to you, Dr. Kenneth Sim, perhaps what's most interesting that came out of the report is that there's a clear need for better preventative care for long-term management of seniors and their caregivers as well. And this comes through loud and clear in the recommendations, doesn't it?
Thank you, Tina. And I guess I want to start off by saying that modern medicine have really come a long way, right, over the years. And we are now at a stage where we have very good blood pressure medication, diabetes medication, cholesterol medicine, right, which significantly reduces the risk of cardiovascular events. But I think we all need to realize that there is still a residual risk here. And as we transition, as our society transitions into an aging population, it's not going to get any easier, right? The challenges of cardiovascular disease that healthcare professionals face will only continue to rise. And I think, even if the residual risks gets smaller with better medications, we have to understand still that cardiovascular disease is still the #1 killer in the world, right? And as the esteemed panelists before me mentioned, that the numbers are just going to keep rising, and to keep up with these challenges, I think that's where innovation is very important, right? We need to continuously improve what we have, our level of care to the patients. And I think over the next few years, it's very important that there is a lot of collaboration here between all the various stakeholders to improve this very level of care.
It segues nicely onto the fact that you say there has been progress made. Professor Tan, that begs the question, what exactly are those innovative medicines that are now available? What are the latest treatments and technologies that can prevent these sort of episodes?
I think as far as progress in medicine is concerned, as far as innovation is concerned, I think it can broadly divide into 2 parts. One is on the medical therapies alone. So that medical therapies will include medicines. It also included some of the new devices for the treatment of certain diseases. Another part of innovation is actually the employment of health technology. So now you can see that the entire, there's a whole momentum in terms of adopting IT technology to help to deliver a much more efficient healthcare, to reduce errors in medical care, and as well as to improve healthcare outcomes in the care of our patients. So these are the 2 important areas of innovations as I see it. Certainly from a cardiovascular perspective, we have now newer medicines that can prevent clot formations, for example, such as anti-clot medicine to prevent stroke in patients with atrial fibrillations. We have new diabetes medicine that actually can reduce heart death in patients with diabetes. And we have heart failure medicines that can actually prolong life of patients with heart failure. These are incredible progress that has made in the last decade, and you will continue to see many of us. But to capitalize on what you say earlier on, actually prevention is still better than cure. So I think prevention is still where we want to go. I think imparting the preventive knowledge to our population is still something very key, and this is where the government, where the ministry, the healthcare agencies, and the families and individuals must come in.
Kelvin, let's turn our attention to health innovation. That's certainly your area of specialty. How can health innovation make real, sustained progress for this health dilemma like heart attack and stroke? How do you see that going forward?
Well, I think if you walk around InnovFest these 2 days, you'll see that we have a lot of digital technologies, and we call it digital health technologies, not just for diagnosis, but also for the preventive part of it. And this is important because sometimes we focus too much on when the disease hits you and then how do you treat it. But one of the main part of the report is the preventive aspects of it. And this is where technologies is here to look at your lifestyle, what you eat, for instance, that if you're at the risk, high risk part, what you should be doing to watch out for your diet. So that's important, that's preventive, right? And there are a couple of them that allow you to use a mobile phone to take the dish you're eating, right? Here in Singapore, we got so many nice food, easily with a sedentary lifestyle, you eat and you just sit there, forget about exercise and you go to sleep, right? So these are very unhealthy trends. And technology is really there to help and remind you that, hey, that 15 minutes, that 20 minutes that you're going to do and walk around and take clock, the 10,000 steps a day is going to, help you in the long run, right? So that's technology at work. The other one is we are seeing also interesting technologies that, for example, one of them is to track the movement of your eye, and see if something is wrong, because there are telltale signs before you have a stroke episode, right? So it will allow technology to, sort of alert you and be cognizant of potential threats to such instances and episodes. And I mentioned data sets are being more easily available because there are more wearables that we are, wearing. Even clothes is a form of wearable today. You can put technologies on it as you wear. It's fashionable enough. It's collecting data, and all this data becomes useful points to understand who you are, and therefore drives personalization of medicine and behavior become more understandable.
So what you're saying actually is that policy must also drive this innovation. How important is that?
Well, I think more conversations, more dialogues, like what Prof. Angelic Chan mentioned, the collaborative element, getting people to talk and open up and discuss topics like this are very important to all of us.
Great. I'm sure there are many questions in the audience. Please do get your questions in. We'll take some questions from you in just a short while. If I could just mention to you, Professor Tan, there were a few red flags that came up from this particular report. One of the most alarming is that the control of risk factors is still suboptimal, and also medical and medication adherence. Maybe you might like to just talk a little bit about that. The need for patients to take seriously, to reduce certain types of foods, and also to stick to their medications. Tell us about that.
So over the years, as I treat patients, we just realized that human beings are highly irrational people. That you know what is right for you, but you don't necessarily go and do the right things right. So many of us would actually know of some of the bad things in life, lack of exercise, unhealthy food, but we do nothing about it as well. And that's the problem with the current situations. We have people with diabetes and yet unable to control their diet, and that results in 1 in 3 people with diabetes having poorly controlled diabetes. In fact, 1 in 3 diabetics also didn't know that they have diabetes when they were first diagnosed, and 50% of people with hypertension don't get to have their blood pressure lowered to the targets that we want. So the key thing here is actually to transform, to translate the knowledge into behavioral change. And this is where whole health life science come in, how the behavioral science part of it. How do we actually persuade people to change their behavior? What is it that motivates them to change their behavior? Can this be done in a financially attractive fashion that you actually reward them with something financial so that they will start walking 10,000 steps a day, or they start losing 1 kilogram a month or something like that. So this part of management and prevention is always our challenge at this point.
Professor Chan, you're very close to the ground. You see what happens in the communities with seniors and their caregivers. Help us to drill down on what we call patient activation, which is actually very important. I'm sure many people would like some clarity around what that is, and also that medication adherence, and what we call polypharmacy, and why it's so important to every single person in this room.
Okay, well, patient activation is basically self-care. The idea that you can actually manage your own health and are activated to do so. In Asia, however, I think our patient activation is still relatively low. And one of the things that I think underlies all of this is that it hasn't, from a sociological point of view, we call it a cultural lag. It hasn't sunk in that you are going to live until 87 years old, and that you need to take care of your health. People have not gotten that idea. Now, polypharmacy, an elder person takes 5 to 8 tablets a day, and if they're all the same color, they get confused. All right, so the next few points are really for the innovators in the room. We need to improve health literacy, okay? Figure out a way to do that. Technology can help support patient and caregiver education. It can also enhance patient-doctor communication. I know there's some technology out there, but we can do more. By empowering older people with more information about health, they can ask questions of their doctors when they come in and have potential risk factors. I think that we need to really encourage and motivate older people and their caregivers to play a more activated role in their own health. And if there's some innovation out there that can do it, then this is an area of real need.
So true, so true. Professor Chan, you touched on some really interesting statistics. Can I have a show of hands here? Who actually thought that was very unusual to hear about so-called polypharmacy, where we have seniors 60 and over who take up to 8 a day? Would anybody say that that's unusual? They've never heard that before, or everyone looks too young to be in that age group now. Whose parents or aunties or grandparents do that? Anybody aware of that? Does that surprise anybody? Does that surprise you? Polypharmacy, 8 tablets or more a day. I mean, that to me is quite staggering. And it just goes to show too that a lot of the people and we've probably got a lot of millennials in the room today, wouldn't even be thinking about that. The fact that has become such a major issue and can certainly contribute to this epidemic. So I think that's really important to remember. Can I just go to you, Dr. Kenneth Sim? The report clearly states that importance of multi-stakeholder collaboration, that word that we've heard quite a bit of today. In other words, we can no longer afford to ignore collaboration in the fight against heart attack and stroke. Now, as an innovator, I'm interested to hear what's your view on collaboration. Can you tell me where is the evidence that proves that collaboration really does make a difference?
Sure. Well, I think that a good place to start off is really to emphasize what Professor Tan and Professor Chan mentioned before regarding the rising challenges of adherence and polypharmacy. I mean, the first bullet point on this Healthy Heart, Healthy Aging report talks about this shift, right, from the traditional treatment approach to preventative medicine approach. I think we all need to realize here the big difference between the two models. In the traditional treatment approach, right, patients want to take medication because they feel unwell, they want to get better. Once we shift to this preventive medicines approach, a lot of these chronic healthcare problems do not present with visible symptoms, right? High blood pressure, high cholesterol. Oftentimes patients feel fine, right? And you know, when you feel fine, you don't really want to take your medications, right? And I think that's how medication adherence grows. Same thing with polypharmacy as well. When we shift to the aging population, people take more and more medications. It becomes increasingly difficult, right, to keep track of all the medications that you have to take. And you know, over 1 year, 2 years, 3 years, people start to question themselves, do I actually need to take 8 pills a day? And you know, that's where all this collaboration really comes in. I mean, since we are in InnovFest, I think a good place to start is potential collaboration between pharmaceutical industry and startup and digital companies, right? I mean, you can always make the best medication in the world, but the best medication in the world won't mean much if the patient isn't actually taking the medication,
Yes.
right? So, you know, any form of platform or tools that can actually improve patient adherence, to encourage patients to take their medication, to make it easier for patients to discuss their healthcare problems with healthcare professionals, is actually a gain, you know, to the society. So that's the first thing. I mean, the second thing is, I mean, Professor Tan is just sitting here with me. Second big point of collaboration is really between the pharmaceutical industry and healthcare professionals, right? I mean, over the years, there are many new forms of medication coming into the market. And I think it's very important for pharmaceutical companies to actually discuss with the healthcare professionals on what all this new medication means, right? What does all these new clinical studies mean? And together with the healthcare professionals, work to translate it into what it means for clinical practice, right? What does it mean for the patients? And I guess the third thing is on the collaboration between pharmaceutical company and academia, right? And I think there's two very good examples here. One of which is recently in Australia, there was a collaboration between Bayer and the Baker Heart and Diabetes Institute, where they actually published a healthcare report called No Second Chances. Now, the report actually really emphasizes the ongoing risk of having a second heart attack or stroke once you have had one episode. And actually, there's actually a big call to action on people to recognize this risk and start preventative medicine. And of course, the second example, which we all need to keep in mind here, is the publication of the Healthy Hearts, Healthy Aging report, which essentially really focuses on the need to recognize the importance of preventative medicine, and of course, how we can collaborate. And you know, all these reports really aim to drive awareness of disease, educating the public on why they need to view all these chronic diseases very seriously. I guess last but not least is also the collaboration between pharmaceutical industry and health authorities and policymakers. Right? We need to consider the access aspect of medication here. Again, you know, once you have new medications, it's all about how do we bring this medication into the hands of the patient. Right? How can we improve approval rates or approval time of new innovative medicines? How can we improve policies, right, to make all these medications more accessible to patients?
Indeed. I wonder if this discussion might spark the creative juices of some people in the audience who now realise that we have a real issue with this. And the answer to this lies right here, and I think that's really important to remember. Kelvin, tell us, how is NUS Enterprise fostering the creative partnerships that we've just been hearing from Kenneth in driving the uptake of new innovation?
I think this is a classic example of the industry, Bayer, working with NUS over a couple of projects. 3 years ago, we have Grant for App, which opens up the call for medication adherence challenge. And we have seen teams from Thailand, from Singapore, providing new insights of how, you know, medication adherence can be a less daunting task for both the patients and, you know, their caregivers. So we have seen, for example, smart pill dispenser, one of the example. The other one is an easier retail distribution and delivery of medicine to the homes. That's a solution from Thailand. So I think as long as the industry is ready to open up that conversation, through defining pain points that they get to know while conversation happen between them and their customers. And that could be also conversation between them and the doctors. And the behavioral insights that Prof. Andrew Chan mentioned, which is the society and the sociology part of it. All these are very important. And I think technology and NUS, what we can do, we are creating platform for all these conversations to happen digitally. I wanted to also mention that technology, while it's good, the attitude towards technology is actually there. We know that it's going to be beneficial, but it's important that as the customer, which is the patient or their caregivers, have that perceived ease of use of technology. So there's some models around this, and I think maybe some research that NUS could do together with the industry will help to provide even more insights to this whole thing.
So important.
I just want to be a little bit more provocative here. So we talk about collaborations between industry, healthcare institutions, and so forth. But since Senior Minister of State is here, let me also say that actually government has got very important role in terms of cardiovascular disease prevention. And there are actually three aspects by which the government can help to lower the cardiovascular burden throughout the world. Number one is actually to provide a essential evidence-based as well as cost-effective care to the populations at affordable care. I don't want to say no cost, but affordable cost to the population. That's number one. Number two, things that governments can do globally is actually to provide legislative measures, actually such as raising the age for cigarette smoking or reducing the sugar content in the beverages. All this only the government can do. The people, the institution, industries cannot do stuff like that. And I think the last part of which is, of course, all governments should work towards improving the general economic health of the populations, because by doing so, you will effectively eliminate some of the disease of poverty, which oftentimes comes with bad lifestyle as well. And you find that people with lower income group tend to eat poorly or don't exercise and so forth. So these are important measures that all governments actually should consider.
Actually, if I can extend that and actually be the devil's advocate and mention to you, Professor Chan, collaboration, we understand, is very, very important. We understand that. The view you take is that we work too much in silos. The left hand does not know what the right hand is doing. And what's that stopping us from being able to achieve? That's a real problem, isn't it?
It is a real problem, but I think that Singapore can actually be a leader in fostering these collaborations. Senior Minister, if I may, really cares about aging and has cared about aging for a very long time. We work very closely with the Ministry of Health and Senior Minister through the Aging Program Office to provide evidence for policy making. For example, CareShield, which was recently launched, the old projections overestimated the young old with disability because they didn't take into account education, and severely underestimated the proportion of the population above the age of 80 that will have disabilities. That's why CareShield has now been tweaked. We've also done work together on caregiving support and provided evidence for the new support plans. A couple days ago, I gave a lecture to practitioners, and I tried to tell them about the work that we've been doing on long-term care services. Quality and convenience are very, very important. So for innovators out there, please think about these issues. Collaborating with policymakers, collaborating with practitioners, and collaborating with researchers. In addition, researchers also the medical, and then also from industry, is the way forward.
Really important points.
I have to say that in Singapore we are somewhat more fortunate because from the top down to the bottom, the vision is very much aligned. From the policy makers to the payers to the healthcare providers, I have to say that the line of communication is always kept open, and we always have this alignment in terms of our vision and strategy. So that's something that drives the efficiency of the local healthcare system here.
But it's not the case throughout the region, though, correct? Yeah. Ladies and gentlemen, let's take some of your questions. I understand we've been getting a few questions through Slido, so let's take a look here. The first question, we may have addressed these already, but let's go through them. What are the latest medical innovations that Bayer can deploy to reduce the effect of CVD? And how is Bayer working with HPB to spread the word right here in Singapore?
So I'll start off by saying that there's a lot of studies on the area of cardiovascular medicine. It is actually one of our key pillars of research in our company. And there are, I guess, two very good examples that I can quote here. One is in the field of atrial fibrillation and stroke. Now, for those of you in the room who are not aware, atrial fibrillation is a heart arrhythmia. And when you have this condition, it really increases the risk of stroke. And studies show that your risk of stroke is increased up to 5 times. Now, over the past 60 years or so, doctors have been prescribing a blood thinner called warfarin to reduce this risk of stroke. But warfarin itself is not a very easy drug to take. Everyone responds to warfarin differently, making the right dose for the right patient very difficult to determine. And the only way to determine the right dose for a particular patient is to go for regular blood tests to find the sweet spot of dose. Now that has been going on for really about 60 years. Roughly about 8 to 10 years ago, there are new anticoagulants, new blood thinners that came into the market that really helped to overcome these limitations that warfarin had. For example, these new anticoagulants has the same dose for every single patient, so you do not need to do a regular blood test to determine the right dose. There are also significantly less drug-drug and food-drug interactions with these new medications, so it makes much easier to take these medications as opposed to the traditional blood thinner of warfarin. So that's the example in atrial fibrillation. Since the introduction of these blood thinners into the market, there have been quite a number of clinical trials to explore how these blood thinners can be used for patients. And recently there was also a trial showing that if you add one of these new blood thinners to the traditional antiplatelet agents, for patients with coronary artery disease, peripheral artery disease that you mentioned earlier, you can actually reduce the risk of cardiovascular outcomes, including mortality. I mean, it's very interesting that not long ago, right, I actually attended this medical conference, and I listened to a global expert, a cardiology expert, talking about how he interacts with his patients. And he was actually saying that as part of the discussion on the patient management, he always asks his patients, what do you think is important in your management? And he told us that the patients always say the same thing. They say, number 1, doctor, I don't want to die. Number 2, I don't want to get a stroke. And number 3, if I have PAD, I don't want to lose my legs. So these are very hard outcomes that really significantly impacts the quality of life the patients and their caregivers have. And it is very nice to see that there are medical advances that Bayer and of course other pharmaceutical companies are doing to meet these increasing challenges.
Okay. If I may, we'll take some more questions very quickly. We've only got a few more minutes to go. The biggest challenges with our multi-stakeholder approach to addressing this problem. Do we need to do things differently to make progress? Professor Tan, would you like to reply?
Well, I think the biggest challenge here is to prioritize exactly what we want to do here. I think to me, the biggest challenge is to get the buy-in from every single stakeholder here, from the government to the healthcare providers to the industry in addressing this cardiovascular problem. For example, I think in terms of adopting some of the medical innovations is a challenge because drugs like what Bayer is producing can be fairly costly to the individual patient. And so to get the drugs to be listed in the standard formulary, to get the ministries to fund this drug therapy and so forth, it's a big challenge, because we have to justify cost effectiveness and so forth. But having said that, there are, of course, progress made along this direction. As I said, in this country, our systems are pretty much aligned. But I think, to me, the biggest challenge here is the ability to actually communicate, to be able to trust in each of the partners here in terms of delivering the best care to our patients.
We asked to the top 3 challenges in behaviour that will help reduce the risk of CVD.
That's quite easy. So as I always tell my patients how to prevent heart attack, first you have to stop smoking, then you have to exercise, then you have to eat healthily, then you have to keep your weight under control, and you have to know how to stress manage yourself.
That's all a
that
piece of cake, isn't it?
Well, that
Professor?
includes actually sleep.
A piece of cake.
Enough sleeps actually. So
Yeah.
I give you 6 changes in behavior that will drive reduction of cardiovascular disease.
Absolutely. And who's heard that before in the audience? We've heard it a few times, but as you mentioned earlier, driving that behaviour, making changes to that behaviour, not so easy. Can we ask how applicable do you find telehealth in addressing the issues raised in the report? Professor Chan, is that something you'd answer?
Well, telehealth is being used in Singapore and is actually quite useful when it's used in the community. We have a couple of studies that look at frequent admitters into the hospital, and the nurses go out into the community and use telehealth to communicate with the doctors in the hospital to make sure that the conditions can be managed within the home. So in that sense, I think telehealth is working.
Well, telehealth was working very well for us until the internet disconnection comes into the hospital. So everything pretty much stops in the public hospital. So I hope this can somehow be corrected. But certainly telehealth has helped us in terms of controlling risk factors. So we are now able to monitor patients' blood pressure from their home. We are able to monitor their pacemaker from functions from their home. We are able to check whether they have taken their medicines to improve drug adherence. We're also able to check on whether they have exercised today, clock 10,000 steps. So in terms of health application, it has been pretty effective.
Ladies and gentlemen, we're going to ask the panel for a lightning round of responses. This lightning round, we're going to confine 20 seconds each and no longer. So this is the question. In 20 seconds or less, please give us the priority from your own point of view, from your area of expertise, to stem the tide of this epidemic. What do we need to prioritize? If we can begin with you, Kelvin.
I think for me, I'll choose collaboration, and that's really important. We should try to use technology as a effective tool to seek effective collaboration. People travel, takes time, resources to do research is very expensive, especially clinical trials or RCTs. So if we can be more open through collaboration to share data, to get evidence-based results, I think the world can be a better place.
Thank you. I mean, to me, it's all about how can we bring the best medications to the hands of the patients. And I like to sum it up by thinking of the 3 A's, right? There's adoption of new medication, there's increasing awareness, which also the report, I believe, emphasizes on. And lastly, there's increasing adherence in the hands of patients. So once they have the drug, how do we ensure that they adhere to the prescribed medication that they have to take to further reduce this risk of cardiovascular disease?
Fantastic.
For me, and I'm really passionate about this, so for all the young innovators here, don't treat older people as a one lump. It's just people 60 and over. Imagine 8 children in a circle and you've developed an educational technology. They're going to pick it up very fast. The older we grow, the less and less similar we are to each other. Replace those 10 children with 10 80-year-olds. put the same technology in the middle, and I can guarantee you that there will not be a reaction to technology in the same way among those 10, 80-year-olds.
My quick reply is creative and innovative communications. You just have to communicate this message to the public in a manner that they understand, whether it's the young, the elderly, and so forth. So this is where education is really the key here.
Some fantastic insights. Ladies and gentlemen, would you please thank Professor Tan Wai Chim, Associate Professor Angelique Chan, Dr. Kenneth Sim, and Mr. Kelvin Tan Cheng Kian. Would you please give them a big round of applause?